Dr. Adamson just went down with a pulse ox of 65.
Yeah, I remember those days. Hello, welcome back to the channel. My name's Ed Hope, your friendly neighbourhood emergency doctor, and today we're going to be checking out the most requested show I think I've ever had on the channel. We're going to be looking at the Pitt. This is a real-time medical drama based in a major trauma centre in Pittsburgh. Sounds like we might be having a few flashbacks, so here we go. This is such a classic look of an emergency medicine doctor. The 5 o'clock shadow, slightly knackered looking, hoodie, water bottle. You may think I'm kind of joking here, but so many people I work with look exactly like this. But also this kind of strut to work, I have it too. It's this feeling that everything has been a nightmare lately, but you're gonna put the best of yourself forward. Yeah, and here is that nightmare I was just talking about. Just a horrible situation to work in, and obviously even worse for patients. Overcrowded, long patient waits, some people probably already admitted but waiting hours for beds, and even people in the waiting room receiving treatment. I know it's a fictional waiting room in Pittsburgh, but this could easily be an A&E waiting room where I work in the UK.
Is it true? Simi told her.
And even just the feel of this walk around here, it has a sense of what it's really like. It really feels like a documentary to me so far, like how lived in the hospital is, the busyness, the untidiness. We can see patients being seen in the corridor, domestic staff cleaning bays around the clock, and just the feel of a department at its limit. But within this chaos, the staff just acting normal, like it's their living room, because you just get acclimatized to this environment.
Unfortunately, the Kraken is still boarding at BH.
Still? Guy's been here for a week waiting on a psych bed.
Yep, he's only getting worse.
Yeah, waiting a week for a psych bed. Definitely something I can relate to. Very realistic and very frustrating. Although not designed this way, emergency departments end up being a catch-all for hospital systems, whereas wards can choose to accept a patient or not and kind of manage their numbers. Emergency departments are like this infinitely expanding area. Now, I'm not blaming the wards for this. They are under-resourced too, but the knock-on effect is we end up managing patients for many days, patients that are destined for wards that, you know, we don't necessarily have the training for. This is not the best place for patients like this.
No more needles!
Oh!
Sir!
No more needles!
Stop!
Sure you want to work today, huh?
They're gonna hurt me! Sir.
Yeah, I mean, as funny as this looks, if this actually happened in my emergency department, like I saw a patient naked running through and security staff chasing them, I don't know if I'd even bat an eye.
So, you know we track every resident's patient seen per hour.
I was just taking her
It's a
history.
brief backstory about what brought them in, not an autobiography.
I was almost done.
Wow, this is all too real. So the only thing that I've ever had raised against me as a doctor was the fact the number of patients I'm seeing per hour was too low. And it's really hard, particularly because you want to spend time and do the best for the patient in front of you. These time pressures have absolutely meant I deliver worse care than I want to. I really feel the pressure when someone asks me to do things that I want to help with, but will take them away from the job that I'm essentially judged on. But equally, I get it. The most important job to help everyone is for us doctors to prioritize the job that only we can do, and that is assessing patients and making plans.
Raised.
And then they come back to...
Waiting room till bed opens up.
For how long?
8 hours if they're lucky. A lot of times 12.
Is it always this busy?
No. It gets a lot busier.
Here we go. This is probably the most accurate 20 seconds of what's happening in emergency care at the moment that you're ever going to get. The shock I see on the med students' faces is something I see every day in patients and relatives, but you know, it shouldn't be a shock. We are screaming about how bad it is, and it's been like this for years. And the thing is, it's human nature to only really care about it when it starts affecting you or your relative, when you're in that situation, and by then it's too late. Like nothing can be done.
As you can see, our house is always packed. And our department is mostly clogged up with boarders. Those are admitted patients waiting for a room upstairs, sometimes for days.
Yeah, again, this is absolutely bang on. Many patients are already admitted under ward teams but are just waiting for beds. They're calling them boarders here. This is such a common thing now that I've actually worked at hospitals where they have dedicated doctors from the ward teams that just work in the emergency department to see these patients. That was a role that just didn't exist when I started in medicine 10 years ago.
You report to them, they report to me. Okay? Great. Senior residents, you got your sign-outs?
Yep.
Yep. Okay, let's do this.
Yeah, great. So on every shift, there is a doctor in charge. They actually changed the name of that from doctor in charge to emergency physician in charge just because the acronym is a little bit more favorable.
9mm GSW to the left shoulder, CT angiogram negative, surgery wants to admit for overnight observation.
Good vitals. They repeat a crit?
Stable crits every 2 hours times 3.
Discharge on Sefton, recheck tomorrow. He'll get way more rest at home.
Here we see a young chap that's had a gunshot wound to his left shoulder. He's had a CT angiogram, so he's had dye put in his blood vessels and a CT done, and that doesn't show any major injury or bleed. And there's no evidence of bleeding because his vital signs are normal, and his crit, or his hematocrit, so the volume percentage of red blood cells in the blood, is normal. What's interesting here is, again, what we're seeing more and more of is ideally you want this patient admitted overnight for observations, and that's probably what the guidelines say and what the surgeons are recommending. However, given the environment and strain on resources, Dr. Robbie opts for a more risky decision to discharge the patient home where he'll be more comfortable and bring him back in the morning for further assessment and a blood test for any evidence of bleeding. So having to do a suboptimal and more risky plan purely because of the state of the healthcare system.
Been cutting back.
How is he still breathing?
That's a lethal dose for you and me. That's happy hour for Louis.
Sobered up, had 2 rounds of lorazepam.
Hold out your hands for me, Louis. Nothing to lorazepam.
So alcohol intoxication here, another common complaint. Patient is showing signs of alcohol withdrawal with the shaking. We have a chart called the CIWA score that we use to quantify the signs and symptoms of how bad a withdrawal is, and this allows us to decide how much chlordiazepoxide, also known as Librium, that we prescribe for the patient's symptoms. Alcohol withdrawal, as well as making you feel like crap, is no laughing matter. Someone with this high levels of tolerance could easily end up having seizures if his withdrawal is not well controlled. And yeah, the fact they know this patient by name too is an all familiar story.
Oh, where's your tooth, Charlie?
If I can find out.
Cancel the discharge, order a chest x-ray. Gotta rule out aspiration.
Yeah. Nice catch. And this is what emergency medicine is all about. Thinking about the most serious issue and trying to rule it out. A tooth in the lung would be no joke, as it's going to sit there and potentially cause a lung collapse or disrupt your mucociliary escalator that helps clean all the gunk out your lungs, so you'd end up getting nasty recurrent infections. And it's super easy to rule this out, as on a chest x-ray, that tooth, if it has gone down into the airways, is going to light up like a beacon.
42-year-old male, Sam Wallace, blunt head with agonal respirations. Dropped down on the T-tracks. Couldn't tube him, LMA in place.
Suicide attempt? Rescue.
This chap here is in very bad shape. Blunt force trauma to the head and now agonal breathing. So these are irregular gasping breaths that people have right before death. Agonal breathing is not going to sustain life. So they've tried and failed to intubate him, and instead they put an LMA in place. So this stands for a laryngeal mask airway. So instead of a tube into the trachea, which can be hard to insert, this is a device that has a mask that fits over the vocal cords and has a cuff that inflates to help keep it in position and help you ventilate the patient.
Degloving injury, right lower leg with open fracture dislocation of the ankle.
Wow. I mean, that looks super realistic. A degloving injury is exactly what it sounds like. Imagine all your skin and soft tissue is the glove, and now imagine removing that glove from the deeper tissue and your bones. The immediate danger here is hypovolemic shock from blood loss, but you need to get the orthopedic and possibly even the vascular teams involved right from the get-go so they can assess her while she's being resuscitated, so they can plan any emergency surgery they need to do to try and save that limb.
I need you on the eat fast. Pupils 4 millimeters and reactive.
Okay, that's encouraging.
Great. Okay, so the chap that's had the traumatic brain injury, we learn has normal pupils, so 4 millimeters and reactive. This is a good sign, as the main concern here would be if he's got intracranial bleed, so a bleed that's expanding in the skull and squashing the brain, and that's what's causing his low conscious level. If this was a bleed and the pressure continued to increase, this would squeeze the brain out the bottom of the skull, what we call brain herniation. This is a near terminal event, and at that point you'd start seeing the pupils becoming dilated, so wider and not reacting to light.
That's a lot more blood than expected.
He's probably anticoagulated for AFib.
Okay, so we see a large external wound, so he's potentially got a depressed skull fracture as well. They mentioned the patient's bleeding a lot more than they expect, and so could the patient be anticoagulated? So these are medications that stop your blood from clotting. You can't really tell on a quick visual inspection if someone's anticoagulated because there are so many other factors, like the size and nature of the injury. How deep the injury is difficult to ascertain, first of all. If there's a particular blood vessel involved, if there just hasn't been enough pressure applied to it, or if the clot has just been disturbed. However, it is super important to find out if anyone with a bleed is anticoagulated, and this person is more likely to be because they have AF on the monitor, and one of the treatments for that is a DOAC, as the doctor has pointed out, which stands for a direct oral anticoagulant.
Did she faint or did she trip off the platform?
Nobody knows. The other guy jumped down, pulled her off the tracks just as the train was rolling in.
What might have made her faint on the platform?
Could be an arrhythmia, cardiac event.
So she needs
EKG and a troponin.
Okay, good.
Yeah, nice. This is absolutely brilliant and goes back to us not wanting to miss serious things. So whenever someone comes in with a fall, you must think about the cause of the fall as well as the consequences of the fall, because patients usually only present with symptoms from one of these. In this case, the woman clearly has a major consequence of the fall with an open fracture, dislocation and degloving of her lower limb, but you must also think of why she fell in the first place. And as they excellently point out here, could it have been caused by a stroke or a cardiac event? Chances are it's just a mechanical fall, but you'd look pretty stupid if you start prepping her for surgery and you've missed one of these.
Do you know how likely patients are to recommend this hospital?
This is an emergency department, not a Taco Bell.
11%.
Well, if you want people to be happier, don't make them wait for 12 hours.
Yeah, so this patient satisfaction score being so low, I mean, this doesn't surprise me. One thing I would add is I do think we've kind of lost the plot a little bit on what matters to patients. And I think there are loads of small improvements that could be made, like making the patient chairs recliners, like more comfortable chairs, not chairs that are built to wait on in an airport. Make over-the-counter medications more accessible to patients rather than having to get a doctor to prescribe them, then a nurse to administer them, and ways to try and communicate more for how long the wait's going to be. I think because no one really wants to acknowledge that these waits are so bad, that no one really wants to put things in place to actually make these long waits, you know, more comfortable for patients.
I have asked you repeatedly to stop referring to the emergency department as the Pitt.
Yeah, so that's why he calls it the Pitt. I had a bit of a nickname for a place that I used to work called the Dark Place. So similar vibes.
You know what's incompatible with the institution's image? Me speaking to the media about people who code in our waiting rooms and people who get shitty care in our hallways waiting for an ICU bed for days.
Cardiac arrest in the waiting room. This is the type of stuff that happens when you have people waiting for hours and hours. With large numbers of patients in the waiting room, it's very difficult to keep eyes on everyone. And some of these patients are going to be sicker than you first thought, and so they're going to be deteriorating whilst they're waiting assessment. Guidelines will say that you need to do regular observations on patients in the waiting room, but when you've just got far more and more patients coming in, at what point can you just not do the things you're supposed to do?
Med student down.
Absolute classic. We've all been there. I've been there. So I've seen this quite a few times. I've even seen it in an experienced surgeon who, during an operation, passed out into the patient's abdomen when it was opened up, and they even had to fish out his glasses from the abdomen afterwards. And yeah, it's happened to me too once while I was assisting in theatre, and it's not always about seeing something gory. Like, working in these environments, they're hot, you're in a gown and a mask, and you can often be on your feet for hours and not really moving. And yet in my case, I felt myself going, took a few steps back and just laid on the floor. Disaster averted.
Good catch on bar fight Billy. There's an aspirated tooth on chest x-ray. Would have been dead in a week from a lung abscess if you let him be discharged.
Ah, there you go. What a great catch. So the x-ray did show a tooth in the airways, so now the patient is going to need to have a bronchoscopy. So that's a camera down into the lungs to fish the tooth out. Otherwise, as they said here, it could block that mucus flow, which could mean an infection would build up and create a lung abscess.
Otis? Otis? Oh, shit. No pulse. Crash cart laying flat.
Oh, crap. So patients passing out from a vasovagal when you're taking blood, very common. Patients having cardiac arrest on you, luckily not so common.
Check a rhythm.
Saline pads. Quick look paddles.
First thing to do, guys, pull the emergency cord. You need more hands on deck. And one of them should be doing CPR, so chest compression, straight away, while the other one is getting him hooked up to a defib. With both of them focused on putting the monitor on, the danger is you get task fixated on that. And if you end up faffing around and having issues trying to sort it, all that time the patient's brain is being deprived of oxygen. Now, that is not discounting how important early defib is, but you need to be doing chest compressions first.
VTech.
Charging at 200. Charged.
Clear.
He's back to normal sinus.
Cool, so the patient is in ventricular tachycardia, so a broad wavy line on the monitor, which is a rhythm that can respond to defibrillation, and they rightly give one shock straight away that puts him back into sinus rhythm. A couple things to note here. The instructions I was always taught to say are stand clear, and you don't say it to the patient. It's not like an instruction to them to get ready to be shocked.
Charged.
Clear.
It's for everyone else in the area, and so you should be looking around the patient to make sure no one else is accidentally touching the patient, including yourself, so that when you discharge the defib, you don't actually put the shock into them and create another casualty. Also, the fact he goes into sinus rhythm here is reassuring, but not necessarily job done. You still need to check he has a pulse before you stop CPR, because the rhythm may look right on the monitor, but you need to make sure the heart is actually creating a circulation.
What happened?
VTech again.
200 joules.
Charged and clear.
The patient goes back into a cardiac arrest. We said before that we must always start chest compression straight away. However, this is actually the only time that we don't have to, and that's because the patient is already hooked up to a monitor and a defib is nearby in a critical care environment and has a witnessed cardiac arrest like we see here. It's acceptable to deliver a shock straight away, as they do here.
What are you doing?
1 gram calcium glutamate, IV push.
We don't have the labs back.
Look at the monitor. Wide QRS and peak T waves, hyperkalaemia.
How do you get that?
Intense exercise caused muscle breakdown, rhabdomyolysis, knocked out his
Sure.
kidneys.
So this makes sense. The diagnosis totally fits. So rhabdomyolysis is the pathological breakdown of your muscles and can happen for a variety of reasons, including extreme overuse in muscles. It's pretty rare, but can happen after marathons. The muscle breakdown products get stuck in your kidneys' filters, meaning your kidneys can't work properly. And one of the key jobs is balancing your electrolytes. Specifically, your potassium can't be excreted. This buildup of potassium in the blood is what we call hyperkalaemia, and it can be fatal as your heart relies on a correct amount of potassium in and outside of the cell to contract properly. And you can actually see these changes on an ECG exactly as they describe here.
Look at the monitor. Wide QRS and peak T waves.
Probably a bit of a mistake here. We didn't see those ECG changes on the heart monitor earlier. And the initial treatment of IV calcium is correct too. So this calcium helps to stabilize the heart muscles so they're more resistant to the high potassium. Although I've never actually seen it play out like this, like treat it before you get the blood test, because you actually need an IV cannula in to give the treatment, and you can quickly do a rapid blood test called a VBG in less than a minute. So usually you have the diagnosis of hyperkalemia super quickly rather than having to give the medication purely based off, you know, a heart trace on the monitor, which can look weird immediately after a cardiac arrest anyway.
Gonna miss the morning arrival of the living dead.
How many are we expecting?
We're getting 3, but 1 died en route.
89-year-old woman from a SNP. History of emphysema, CHF, MS, VFib, unresponsive to 3 shocks.
Yeah, okay. So the one thing I was going to comment on the fact that this wasn't realistic is that most of the patients we've seen are fairly young. In reality, the vast majority of emergency admissions are in the elderly. And coming in as a cardiac arrest is also maybe not as common as you see in medical TV shows.
Lucas chest compression system.
Robotic CPR.
We see a Lucas machine. I've only been involved in a few cardiac arrests with one of these, and it does feel quite strange at first. Like you should be doing more, as normal CPR requires so many people to be on the chest to rotate through chest compressions because it's so tiring to do. So using Lucas results in much quieter cardiac arrest because there are fewer people needed.
Is there an advanced directive?
No, full cope for the nursing home.
Seriously?
The team are hinting that CPR in this patient probably isn't in her best interest, and it's difficult to tell when you're in this moment because you don't know the full patient history and their baseline. That's why advanced directive forms are useful to communicate to healthcare teams ahead of time what people's wishes are. And we see here how brutal CPR can be, with tubes down your throat and having your chest pumped, and even the best case scenario that the heart begins to beat, this patient would still need to survive a lengthy stay in ICU to recover, and that is unlikely to be successful for patients who are frail or who have multiple comorbidities. And it doesn't fix the underlying issue that led to the cardiac arrest in the first place. So ideally, we should communicate ahead of time with these patients to prevent them from having to go through unnecessary CPR and preserve their dignity in their last moments. Death is a normal thing, and it's not the job of a doctor just to do everything possible to every single patient when it's not going to have any good outcome for them.
Heart rate 130, BP 90 over 60, gave him 500 cc's, normal saline.
Hi, Mr. Spencer. I'm Dr. King. This is Dr. Collins. How are you feeling today?
Is it dinner time?
IV fluids and medications are fine, but no intubation and no chest compressions.
That's helpful.
Course Ronchi here.
Right middle lobe infiltrate.
Probably not the most exciting patient we've seen so far, but this is definitely the most realistic. Firstly, the patient has an advanced directive, so we already know the ceiling of care that is suitable for this patient, unlike in the last one. So we have an elderly gentleman with a background of Alzheimer's from assisted living who has a fever, low blood pressure and a fast heart rate, and they find he has a right middle lobe pneumonia, so they're treating for sepsis. I found sepsis to be poorly understood by the general public, who often think it's an infection in your blood. While certainly an infection in your blood can cause sepsis, sepsis is an infection anywhere in your body, but the immune response from that area travels around the body and causes your blood vessels to dilate and become more leaky. So it's a dysregulated immune response to infection, usually a serious infection, and this change in your blood vessels drops your blood pressure and leads to your other organs being starved of oxygen. That's why this gentleman here has low blood pressure and a fast heart rate. The heart rate is trying to keep up with that low blood pressure. And in the case of the infection, it's coming from a pneumonia, so an infection in the air sacs of the lung. And yet there is a bundle of things that you need to do as a doctor that has shown to improve outcomes. So we do a blood test and monitor the urine output, and that's to keep an eye on that organ damage. We give fluids and consider oxygen to try and maintain perfusion to the organs. a blood culture sent away to try and identify the infection. And while we wait for that, we start antibiotics immediately on what we think is most likely the bacteria given the location of the infection. So you now know everything there is to know about sepsis, and this is just a patient you'll see multiple times a day in A&Es up and down the country.
Stop. Call it. Nursing home just faxed us a DNR.
You kidding?
Power out the defibrillator and the
Complete
Lucas.
waste of time and money. Who the hell works at that place?
A nurse taking care of 60 patients who couldn't find the form.
She called 911 so she could take care of the other.
I like how understanding Dr. Robbie is here. When things are so bad, you can get into this victim mindset of thinking everyone is against you, when in fact, everyone is struggling and just trying their best. One thing though, faxing a DNA CPR form is kind of dodgy. I know this is set in the US, so perhaps something different, but in the UK, something as important as a DNA CPR form needs to be the original form to be valid, because although unlikely, these forms can change. So the care home may have faxed a previous form, but the original may have subsequently been altered. So a small detail, but just something to note.
One of the things we do here is to take a moment of silence when we lose a patient.
You eat fatty food, there can be pain when the gallbladder contracts. Oh, bingo. 1 stone, there it is.
You want an EKG?
For
Heart attacks can present as upper abdominal pain.
Yeah, very good. So this is an example of what we call early diagnostic closure. So the medical student thought the patient might have gallstones and only asked questions and did an ultrasound to look for gallstones, didn't consider anything else. And so it could be something like a heart attack. And the patient has risk factors for that too. So they have hypertension. So it's not all about throwing that bullseye and getting the diagnosis perfectly straight away. You want to ask other questions to rule out the more serious things.
I'm going as fast as I can. I'm picking up 2 more patients.
Yeah, I feel your pain.
Intubate here.
Dr. Adamson just went down with a pulse ox of 65.
Yeah, I remember those days. Almost seems like a bad dream now. And I can totally understand how you can find it fine in the moment, but more difficult thinking back, because at the time you don't really have any chance to sort of catch up and take in what is actually happening. One of the things that I'll never forget, which was probably the worst experience I had during COVID, was when I looked back at the worst day I had. So this was a few weeks in the future by this point, but I'd seen around 10 patients on a particular day in the middle of the biggest wave that I was involved with. And I just thought I'd check up on the patients I'd seen, all very similar, you know, with shortness of breath, some of them extremely scared. And when you look back at your patients, they appear with like a blackboard around if they'd passed away. And half of the patients I'd seen that day had died. And it's so difficult to try and process what those patients were going through in those scary moments, struggling to breathe, being treated by people in masks, lacking that human touch and with limited ability to see their relatives. We are used to people dying occasionally, but not in that number and not in that environment. So there you have it. What an absolute masterpiece. That is the most realistic medical TV show I've ever seen. The hospital felt untidy and busy and at its limit, and that was very realistic. The characters, they weren't these slick Hollywood actors. I mean, the actors are great, but they felt like real people that you'd work with. And the medical cases were pretty extreme, but every day you do see something a little bit different. So that was absolutely brilliant. So thank you to you guys for recommending I check this out. I hope you've enjoyed my thoughts on this. And if you have, please give it a like and comment down below. I guess if you want me to check out more episodes of this or any other TV shows, then please leave me a comment. I hope you're all well, and I'll be back soon.